All right, I think we can start right now. Hello, everyone. My name is Mohammed Jamal. I'm a surgical resident in the Kuwaiti Board of General Surgery. I will be your host for today's session. I would like to first welcome everyone from all around the world. We have so far 250 participants joining in, and the numbers keep on increasing. And I would like to welcome our host for today's session, Dr. Badr AlShaban, who will give us a talk about inflammatory bowel diseases. Dr. Badr AlShaban finished his general surgery residency in Jackson Memorial Hospital, University of Miami, and he did his fellowship in colorectal surgery in the University of Miami. He worked in Mubarak Hospital as a specialist in general and colorectal surgery, and he's currently the chief of colorectal division in Jabir Al-Ahmed Hospital. Welcome, Dr. Badr AlShaban, and we're honored and privileged to have you on our platform today.
Thank you very much. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you very much for having me, and I would like to thank the Kuwait Association of Surgery and ACS chapter and Surg Kuwait for hosting these lovely talks. Today's talk that will be presented by yours truly is going to be discussing inflammatory bowel diseases. As I was saying, we're going to be talking about inflammatory bowel disease. Ulcerative colitis and Crohn's have really never been properly described until the 19th century, namely 1859 and 1932. They have been described as relapsing inflammatory conditions of the gastrointestinal tract with distinct yet overlapping clinical and pathological features due to the shared and yet disparate pathophysiologies and pathobiologies of each. So, what can cause Crohn's? What can cause ulcerative colitis? There's a lot of theories, mostly rotating around the trigger theory, whereby you may have some predisposing factors, either genetic or acquired, and on top of environmental factors, there might be either a causation or alteration in the course of the disease. Some of these environmental factors have been noted to be smoking, whereby smoking has been shown to either increase the risk of an activity of Crohn's disease, and ulcerative colitis have been shown to be, smoking has shown to be somewhat having a protective effect in ulcerative colitis. Non-steroidals have shown an increased activity in inflammatory bowel disease in general. There is a myriad of host factors whereby genetic predisposition and familial history clusters have shown increased risk and likelihood of forming inflammatory bowel diseases. Geographical locations based and inferred from data such as multiple sclerosis and being tested on inflammatory bowel disease have shown that geographical location does have an effect on the likelihood of developing inflammatory bowel disease, to the point that even if you migrate at a certain age from an area with low likelihood to an area of high likelihood, eventually there will be a pickup in the increase in the likelihood of development of those IBDs according to the new geographical area. The diagnosis, in terms of history, with ulcerative colitis, it tends to be bloody diarrhea, it tends to be painful, and the patient might experience the feeling of tenesmus. And to those people who are not sure what the meaning of tenesmus is, it's the sensation of incomplete emptying after going to the bathroom, and it's usually associated with a level of proctitis or rectal inflammation. It's important to rule out history of travel, where there might be tropical or infectious diseases, where there might be antibiotics used, whether the patient might have any history of immune suppression, or the presence of perianal disease might indicate other diagnoses other than ulcerative colitis. With Crohn's disease, it tends to be similar to ulcerative colitis, but it tends to present anywhere in the GI tract. It tends to be transmural, unlike the submucosal and the mucosal nature of the ulcerative colitis. Patients tend to present into 1/3 clusters of either ileocolic disease or perianal disease, or the last third would be in multiple sites. Skin lesions tend to be more common with Crohn's disease, however, they do present in both populations. Extraintestinal manifestations, there's a whole list of them. The ones that are highlighted in bold tends to be the most significant ones in terms of disability to the patient or causing a significant effect in their life. When it comes to the skin, namely, it's going to be erythema nodosum and pyoderma gangrenosum. And of note, erythema nodosum tends to be slightly more prevalent with Crohn's disease, and the pyoderma gangrenosum tends to be slightly more prevalent with the ulcerative colitis. In the hepatobiliary system, primary sclerosing cholangitis seems to be the biggest problem that we may face with IBD patients. In terms of the vascular system, hypercoagulability is something that we should always be aware of, and they do have a slightly higher risk of thrombosis and DVT formation. When it comes to the musculoskeletal system, peripheral and large joint arthritis seems to be the biggest problem, and when it comes to the eyes, uveitis is the most debilitating out of all these complications. And when it comes to operating on these patients, it is worthwhile noting that out of all of these extraintestinal manifestations, the one that tends to improve the most is the erythema nodosum, unlike the others, which do tend to persist after operating on the patient sometimes. Crohn's is classically known to be transmural inflammation, thereby affecting the mucosa, the submucosa, the muscular layer, all the way up to the serosa, and that's why sometimes the disease with this perforate on the long-term cirrhosis and fibrosis. And there are skip lesions in the Crohn's, as we all know. With ulcerative colitis, however, it tends to be of a continuous nature. I'm sorry, is my connection okay?
Yes, doctor, I can hear you.
All right, I apologize. I'm just getting a lot of warning of unstable connection. With the ulcerative colitis, it tends to be continuous in nature. It tends to restrict itself to the submucosa, unlike the nature of Crohn's, where it, like I said, it's transmural. And just to note what I just said, ulcerative colitis tends to be continuous. It goes from a distal point to a proximal point. Sometimes you might have what's called rectal sparing. It tends to be at variable distances, and sometimes you might hear somebody having UC that is distal versus pancolitis UC. The distal tends to be from the splenic flexure going downwards. Some patients might have what's called backwash ileitis. If they have an incompetent ileocecal valve, you'll have some backwash of the inflammatory materials that are causing similar inflammation in the terminal area. It's transmucosal. Sometimes it goes to the submucosa. As it progresses further, it can cause crypt abscesses and mucin depletion. And as it decreases the severity on a histological and a pathological examination, it tends to become more and more similar to Crohn's disease. Crohn's disease, on the other hand, like I said, it can be in any point of the GI tract with certain preferences to prevalences, which is what I was just saying, about a third of them tends to be ileocolic, and a third tends to be perianal, and a third tends to be anywhere else in the GI tract. Creeping fat is a strong feature, especially on a clinical examination and on a macroscopic feature. As the inflammation progresses on the mucosal and the endoluminal level, aphthous ulcers may coalesce to form cobblestone mucosa. The transmural inflammation goes all the way up to the serosa, and this ends up with stenosing, stricturing, penetrating, and fistulizing diseases. There is an entity that is called an indeterminate colitis. This should be reserved to cases where even after full excisional histopathological analysis, neither Crohn's disease nor ulcerative colitis is diagnosed. This may present with about 10 to 15% of histopathological samples that are sent to the pathology department after a completion of proctocolectomy. So this is something that may need to be that need to warrant discussion with your patients, and that in certain situations, namely 10 to 15% of the patients, especially in the ones that tend to present with severe disease from the point of diagnosis, that after full excision, the diagnosis might change, and the final plan of surgical management might also change. Other cholitides that the patients may present with, and it's a differential diagnosis that you have to think about, and we mentioned them earlier, things such as infectious colitis is something that you have to rule out. Ischemic colitis is something that you might have to consider. Segmental colitis, that is also otherwise known as diverticulitis, is something that you may come across. Other forms of colitis that we will not be discussing here, sometimes we refer to microscopic colitis and collagenous colitis, but these are going to be for a different discussion. Serology ASCA and the P-ANCA in the older days were referred and relied upon to help in the inclusion or the exclusion of the diagnosis of Crohn's disease or ulcerative colitis. However, they are not so useful anymore, especially in the sense the presence of rheumatological diseases. They tend to have a high false negative and positive rates. However, they have a stronger presence overall in Crohn's disease than ulcerative colitis. Fecal markers, namely calprotectin, is a calcium-binding protein that was recently introduced into the management of IBD patients. It is an indicator of mucosal inflammation. It's a non-specific indicator, and therefore it may be present in infectious colitis, other forms of colitis. It may also occur with mucosal bleeding. It may occur with the use of non-steroidal anti-inflammatory drugs, and it may also be present with malignancy. So it's not really a useful marker for diagnosis, but it is a useful marker for following, or whenever you might have a patient and you're unsure whether you might think or consider putting him through a colonoscopy to rule out inflammatory bowel disease. In the same way that we use the CRP and the ESR, because they just present with the acute phases. However, they're not very highly sensitive or specific towards the disease. It's a whole different chapter that I'm not going to pretend like I know what I'm talking about. But genetics are known to play a role in IBD patients in the certain setting whereby environmental factors may trigger those genes to either upregulate or downregulate certain immunity aspects or protein presence or antibodies in those patients. Gut microbial environment have also been known to alter these genes in terms of upregulation or downregulation and the overall course of progression of IBD patients. Endoscopy and inflammatory bowel disease, I think, is one of the cornerstones that should never be ignored. It remains a gold standard for visualizing the bowel and obtaining tissue diagnosis of the disease. It allows therapeutic options in terms of biopsy, injection, or balloon dilatations. It allows to delineate the normal from the abnormal areas that might be put under question from radiological examinations. Now, we do have to discuss with the patient that there's a slightly higher risk of perforation, maybe it goes up from the classical 1 in 1,000 up to 1 in 100. I still think that it is relatively low percentage. However, it is something that may be warranted to discuss with your patient. And in the good experience as of our gastroenterologists, I do not think that this is any serious concern these days. It can also help in the assessing of the response of the treatment that you start your patients on. In these two collection of images on the left, the first 6 images shows the different levels of activity of Crohn's disease on endoscopy. Images A and B are basically the punctate mucosal erythema that you might find in a patient. Between B and C is the formation of the aphthous ulcers. And as the aphthous ulcers progress further, they dig into the submucosa where they might cause submucosal abscesses. And eventually in E is what you see as the coalition of the aphthous ulcers into what's called serpentine ulcers. And eventually you get the cobblestone mucosal formation in image F. On the right side are the 4 images in comparison to ulcerative colitis, where you can appreciate some similarity in the earlier stages. And as the disease kind of progresses, there is some differences in what you might see. Radiologically, I think that a small bowel follow-through or small bowel enteroclysis should not really be used these days, especially in the availability of computed tomography and magnetic resonance imaging. MRI should be the golden standard when the patient is a non-emergency situation. An MR enterography is an excellent way to evaluate the small bowel. It provides less radiation and it can give you further information than the CT by delineating whether the inflammation is stenotic or inflammatory in nature, or it's just a scar. And this can help guide the treatment and decision-making for surgery. An MRI pelvis has a very important role in delineating complex perianal disease, whereby you might have multiple openings on the external or the internal part, and some of them can be very difficult to negotiate operatively. Computed tomography is a good advantage, especially in the emergency setting. It can help differentiate a patient who might have a simple flare-up than a patient who might have had complications such as a free perforation or an abscess formation. And the CT and the MRI, in comparison to the fluoroscopy, have the advantage of showing you extraluminal examinations, whereby you might be able to appreciate fistula formation, abscesses, or other entities. And the images, as you may notice, are inflammatory points in the small bowel. Some of them are stenotic in nature, where causing proximal dilatation, and some of them are long inflammatory in nature without any obstruction. And it is important to note that all these three patients may present with tendinous leukocytosis, and some a decision to operate may never be appreciated, or may never become easier until you do perform these necessary investigations. Starting with medical therapy, medical treatment of ulcerative colitis. In general, it follows either a bottom-up or a top-to-down principles. And these basically take into consideration the clinical status of the patient upon diagnosis and initiation of treatment. So in other words, when a patient presents with mild disease and mild symptoms, you might be starting with the simpler medications that might be better tolerated. And if the patient presents with a more severe disease, then you might start with the bigger guns, and you may wean them down as the patient improves. The options that are available for UC patients in general are either sulfalazine, 6-mercaptopurine, which is also known as Purinol, azathioprine, which is also known Imuran. Then there's a whole class of biologics or immune suppressions. And then there's the cyclosporin and tacrolimus class of drugs, which are also known as calcineurin inhibitors. And finally, methotrexate. So going over these drugs one by one first, and I apologize ahead of time because there will be a lot of overlap in what I'm going to be saying. But that also goes back to the principle that there's a lot of overlap in either the management or the, overall the management of these patients, depending on how they present and how they respond throughout the course of the treatment. So the first drug, as I was saying, is sulfalazine. It is an aminosalicylic acid. Mesalamine is also another option for it because it does not contain any sulfa, which means it's better tolerated. However, it is more expensive in formulation. Some of them have an enteral effect when they're provided an oral tablet, and some of them have a topical effect when they're provided in suppositories or enemas. The mechanism of action is also dependent on the formulation of these drugs. So some of them are time-release, such as Pentasa, and some of them are pH-dependent, such as the Acicol and the Lialda drugs. For example, as the pill detects the changes in the pH in the transition from the distal ileum towards the ascending colon, then those pills start dissolving and releasing their contents. The delivery method will be catered towards the location of the disease in general, and therefore the optimal dose will be delivery dependent. It is generally useful to use mesalamine or sulfalazine for induction and maintenance, but the disadvantage is that it's hard to lower the drugs while maintaining remission. And an important thing to note is that it does not have any protective effect in terms of protecting from cancer down the line. So it's important to remember that with patients that present with very mild disease, that do not have significant symptoms, but do have still a microscopic evidence of ulcerative colitis and are maintained on ASA drugs, they are not out of the window of cancer risk down the line. Next class of drugs belonging to immune suppression is the azathioprine and the mercaptopurine. These are frequently used as a bridge when you induce a patient with steroids or biologics. They take a while to activate, up to 3 months to kick in and have a full effect. It's imperative that you check your patients for TMPT enzyme deficiency, because if your patient is deficient in that enzyme, you're going to run a very high risk of severe myelosuppression in these patients, and therefore these drugs are not suitable for these patients. Cyclosporin and tacrolimus are very potent immunosuppressants. They were imported from our colleagues in transplant specialties. They utilize the calcineurin inhibition pathways. They were commonly used as rescue infusions with a high risk of nephrotoxicity, hepatotoxicity, and neurotoxicity. And it is also important to note the fact that there is a very long-term association between patients that stay on these drugs for a long time and lymphoma or squamous cell carcinoma. It is not exactly known what is the risk. However, it is known that there is a slight risk. It's actually not a slight risk, it's a considerate risk. In some papers, up to 70 times the odds ratio of squamous cell carcinoma, and it tends to also be aggressive. Methotrexate is not really commonly used in ulcerative colitis. That means that I have seen a couple of patients that have done well on courses of methotrexate.
Doctor?
Moving on to biologics, which are the, yes?
Sorry, can you repeat the last information, because it was cutting, and don't worry about the repeating. So the last information.
Cyclosporin?
Yes.
Okay, so as I was saying, cyclosporin was utilized earlier as a rescue infusion in patients that present with severe forms of ulcerative colitis that may not necessarily respond to IV hydrocortisone in the first couple of days. It is a very potent immunosuppressant that was important from our colleagues from the transplant specialties. However, due to its high-risk profile with nephrotoxicity and hepatotoxicity and neurotoxicity, it didn't really gain significant popularity among our gastroenterologists. And finally, methotrexate is not really indicated for ulcerative colitis, but I have seen it, a couple of patients used it. I don't necessarily, it's not something that I would necessarily prescribe for my patients. So I will be discussing a little further under the Crohn's diseases management. Biologics are the gold star of IBD nowadays. Remicade, which is generically known as infliximab, it is a monoclonal anti-tumor necrosis factor alpha antibody. It is a chimeric antibody, which means it was harvested from mouse and humans. It takes a while to induce it with patients, and it can take up to 2 months to induce it. And the reason is you don't want to have any antibody-resistant developments, to the point that it is also indicated when you initiate the patients on these therapies that you have to measure the serum antibody halfway through the induction process. And if the patient does develop a certain level of serum antibodies, then it is also recommended to double the dose in order to increase the efficacy of Remicade. Due to the nature and the pharmacokinetics of these drugs, they are known to activate latent infections, and therefore it is imperative that the treating physician should be checking for any TB, any history of hepatitis B, and sometimes even CMV virus exposure. There's an unknown but a documented risk of lymphoma, and luckily it does not have any increased risk of perioperative complications. The next biological injection that was developed was the adalimumab, which is also known as Humira. Unlike the chimeric nature of Remicade, it is 100% humanized anti-TNF alpha antibody. It is slightly less powerful, but it is indicated in moderate to severe inflammatory bowel diseases that do eventually develop antibodies and resistance to Remicade. Next two classes of anti-TNFs are Cimzia and Simponi. Cimzia is approved for Crohn's disease and is only approved for ulcerative colitis in trial recruitments. However, Simponi is approved for ulcerative colitis. Moving on with biologics, the next classification or subclassification of biologics, I suppose, would be the monoclonal anti-integrin antibodies. They're also known as lymphocyte pair patches adhesion molecule antibodies. Two drugs that we have used are Entyvio and Tysabri. I'm not even going to try pronouncing them anymore. They work by upregulating the anti-inflammatory process. Entyvio has been noted to have a strong association with perioperative complication compared to other or previous biologics. However, it has been licensed to induce or in remission or for patients that have loss of activity due to previous biologics. It is important that Entyvio and Tysabri should only be initiated by themselves and not in conjunction with other biologics, because you run the risk of progressive multifocal leukoencephalopathy, which is a very dangerous complication and is something that is unnecessary, needless to say. Steroids, another cornerstone in the treatment of IBD. It is used for induction, however, it is not logical to maintain any patients on steroids due to the well-known complications of Cushing disease. And due to the known fact of dependency and resistance that the body eventually forms to these drugs. There's no role of dosing your patient beyond 40 milligrams of prednisolone per day, or the equivalent of 300 milligrams of hydrocortisone intravenous. But an important thing to know is that the osteoporosis is an irreversible, unfortunate complication, unlike most other complications that do reverse once we win the patients down. It is the drug that is highest risk association of perioperative anastomotic leaks, and that must be taken into consideration with your surgical decision making. And out of all the steroids that we may use, budesonide has a good topical enteric use, but it is really limited to mild ileal disease, and I haven't really been seeing. I really haven't seen it being used in UC patients. There's always the notion of a Addisonian crisis when you're weaning down your patients off long-term steroid use. However, I think in the recent past, these points have been put to challenge, whereby there have been a couple of trials where patients have not had any stress doses perioperatively, and there has not been any evidence of increase in hypertensive episodes perioperatively, or especially intraoperatively. So you always have to weigh the risk and benefits of overdosing your patients with steroids if they are being chronically on it. Treatment of ulcerative colitis according to severity. Now that we're done with the different classes of drugs, we're going to treat them according to severity. When you have a patient that has mild to moderate UC, using sulfasalazine or mesalamine is a good option for induction and maintenance. Steroids may be used for induction as an alternative drug. The location or the spread of the UC will dictate the method of delivery and the optimal dose of delivery, whether it may be a foam or an enema, a suppository, or an oral formulary. When you move on to more moderate or extensive disease, it's more prudent to start the patient on oral prednisolone. Thiopurines such as Imuran or Purinol may be used for induction and maintenance. However, they do have a slower onset when compared to biologics. And it is important that when you use these two drugs that they must be bridged over steroids in order to avoid complications. Biologics, namely Remicade, have a slightly higher chance of success and response to induction, and the response is usually quicker. And it is easier to discontinue when the patient shows no response. Luckily, with biologics, especially Remicade, as I was saying, 60% will remain steroid-free at 1 year whenever you transition them off steroids. You may combine biologics with thiopurines, but that is usually reserved for the more severe disease. And whenever you have a patient with severe colitis, it is important that you start them on IV hydrocortisone rather than oral prednisolone, because that improves your drug delivery. It is important that you involve surgical consultation in order to help with the assessment of the management of the patient. It is also important, I think it's important to involve the surgical colleagues in the early assessment of the patient, because it's unfair to call them when it is down the very end of your management, because the surgeon really has no baseline to start off with when they're suddenly encountered with a very sick patient, versus when they've had the opportunity to see the patient a day or 2 or 3 or even 4 days before that, and they are more convinced that the patient will need a surgical intervention as soon as possible, because for the last 3 or 4 days they haven't responded to any of your upscaling of treatment. Bowel rest is important, IV hydration is important, providing adequate nutritional support for your patient is important. Antibiotic coverage is not really supported by evidence. It is anecdotal, because we know of some evidence of translocation whenever those patients get really sick. And because whenever you see the patient for the first time, it is important to rule out infectious colitis, and therefore covering them with empiric antibiotics might not be a bad idea. Severe acute colitis, fulminant colitis, toxic colitis, they all tend to be named back and forth. It is important to be able to identify what is a systemic sense. These are the 2 important factors recognized rather than the naming terminology of the disease, because it is the severity and the toxicity of the patient that will dictate your eventual management. Whenever your patient fails IV hydrocortisone, like I was saying earlier on, there's the option of cyclosporin infusion. However, due to its toxicity, it never really gained popularity. It is highly effective, but the problem with cyclosporin infusion, it is hard to wean off your patients off that infusion. And whenever you do wean them off, a lot of them relapse, and eventually half of those patients will require surgery while they're still an inpatient. Infliximab, on the other hand, it has the advantage of maintenance rather than, which obviously the cyclosporin doesn't have over the longer period, and it is significantly less toxic with your patient, and it is associated with a lower perioperative complication profile than cyclosporin. And eventually, if your patient fails all these previous modalities, then colectomy should always be an option on the table. Moving on to Crohn's disease, a lot of the initiation of the treatment of your Crohn's disease will be under the arms of your gastroenterologist rather than your colorectal surgeon. And they do tend to use classification diseases. However, I do think that for surgeons, applying scoring classifications is hard to translate to a clinical or a surgical decision, namely because they haven't been really challenged with that perspective. The biggest 2 classifications that are used for Crohn's disease are the Montreal classification, which relies on the age, the location of the disease, and the behavior of the disease, such as penetrating, fistulizing. And as I was mentioning earlier, perianal is a modifier in the Montreal classification because it in itself represents a slightly higher activity. The next classification is the Crohn's disease activity index, and although I've seen it around a lot, but I really don't think that it is very useful outside a trial parameter, because it relies on a lot of symptoms and how these symptoms change rather than on absolute values. Probiotics have been coming recently into the field of treatment of Crohn's disease. All I can say is that I appreciate their importance in maintaining a good gut and a GI microbiome, because that in itself eventually will affect the immunity of your gastrointestinal system and the overall health of the patient. However, we are still lacking evidence to their effectiveness in induction or maintenance. And I do slightly have to apologize. I have to get the charger before the battery runs out.
So we'll continue in just a few seconds. Thank you. Hello, do you hear us?
I'm back. Yes.
Yes.
Yes. Is everything okay?
Yes.
I really apologize for what just happened. Moving on from probiotics, antibiotics have been known and they do show some evidence of efficacy in Crohn's disease. The most notable antibiotics has been metronidazole. It has been studied in mild disease. Ciprofloxacin have been shown to have an added effect. However, the use of Cipro by itself is not of any benefit. And you have to be careful of long-term complications of antibiotics use, especially with metronidazole. Permanent peripheral neuropathy can be present in up to half of patients that go on high doses of flagyl. Finally, sulfalazine, I don't think that it is very effective, especially nowadays with the availability of the other agents. Steroids are another cornerstone in the treatment of Crohn's disease. Budenoside, which is also known as an anticord, is a good oral agent that has minimal systemic activity because it has an extensive first-pass metabolism whenever it goes through the liver. Other forms of steroids are prednisone and hydrocortisone. They do form resistance over time. They do show dependency. So therefore, they are ineffective for maintenance of remission, especially budenoside when compared to placebo. Immune disease, again, thiopurines such as Imuran and Purinol, they take a while to have a full effect, up to 3 months. They do have a durable effect, but you have to bridge them over from steroids. Sometimes they may be used in combination with biologics. They're good for maintenance of remission. However, you do have to watch out for severe myelosuppression if your patient does have a deficiency in the TMPT enzyme. And finally, methotrexate, as I was mentioning earlier, have been well established in the maintenance of remission when it's used in low doses. But you have to watch out its teratogenic effects and its toxicity. Biologics, Remicade, Humira, and Cimzia are all the anti-TNFs that are approved in Crohn's disease. Simponi is not approved and is approved for ulcerative colitis. Remicade tends to be the first line of biologics that is used for Crohn's disease, and whoever shows resistance with antibody formation may be upgraded to Humira. And finally, Cimzia may be used after the failure of the previous 2 other biologics. You have to watch out for latent infections, as I was mentioning earlier. There's a slight but an unknown risk of lymphoma. These biologics are contraindicated in active infection. So if your patient presents with an abscess or UTI or an infected fistula or any kind of other active ongoing infection, so it is imperative to stop these biologics. Finally, Tisabri and Entyvio are both anti-integrin antagonists. They show their evidence by 2 to 3 months. If there's no response within 3 months, or you fail to wean the steroids within 6 months, then you need to stop it. And you cannot use it with other anti-TNFs, or you run the risk of PML. Induction of remission in Crohn's disease. We can't use steroids for the aforementioned reasons. Thiopurines and methotrexate should not be used alone, but should be bridged over steroids. And biologics may be used as a bridge over steroids or in combination with immune modulation. Induction of remission in mild Crohn's disease. Now, I have to say before I start the different subclassification in those managements, the majority of the trials and the data and the drugs that are available nowadays are targeted towards a lower GI of Crohn's disease, and therefore there isn't a lot of data that is available for upper GI. And therefore you'll see a similar points of management whether your patient has mild or moderate disease. So when you usually either steroids or immune modulators, when you isolated mild disease, bedenoside or anticort is the safest and simplest option. When you have limited ileocolic disease, sulfalazine may be used at that point, or you may just jump onto oral steroids before you cross them over to something else. When you have moderate disease activity, the ileum may be upgraded from anticort to systemic steroids. Systemic steroids may be transitioned over thiopurines, and you may consider biologics when your patient is not a good candidate for these points of management. When you have colonic Crohn's, it is probably better to start off with systemic steroids, and then you transition them over either to biologics or it might be a good idea to discuss some surgical options, or at least use the thought of surgical management in your patients.
Sorry, doctor, could you repeat the last point because the internet was interrupting? The last point, please.
Mild?
Yes.
Okay. So as I was saying, with mild Crohn's disease, because of the majority of trials and evidence data has been pointed towards a lower GI, there isn't so much data towards the management of upper GI with the newer availability of drugs. And therefore, you'll see that the majority of the recommendations for upper GI Crohn's, due to scarcity, is limited within steroids and immune modulators. With limited ileal mild disease, the good option to start off with is bedenoside, which is also known as anticort. However, when the disease is ileocolic, which is the majority of what the patients present with, it may be a good idea. It might be worthwhile trying sulfalazine, but I think the majority of physicians nowadays start with systemic steroids. When the patient is a little bit more active than a mild and is categorized as a moderate Crohn's disease, it might be worthwhile to jump straight to systemic steroids, and these steroids might either be bridged over to thiopurines or biologics. When it's colonic Crohn's, again, it might be worthwhile to jump into systemic steroids and biologics or thiopurines, and it might be worthwhile to start discussing or putting into your patient's head the thought of seeing a surgeon in order to be on board from early on should there be any complications down the line or failure to respond to treatment. When the patient is presenting with severe Crohn's, then systemic steroids are warranted, and you might have to start them earlier on biologics and immune modulator, and surgical options should definitely be introduced to your patient. When you want to maintain your patient, there are certain principles. If remission is achieved with steroids, thiopurines or methotrexate should be bridged over for maintenance. Relapses may require increasing the dose. If the remission, however, was maintained using a biologic, then the biologic should be continued for maintenance. And biologics and thiopurines should be considered for higher remission success should the patient not be responding to either class of medications. And there should always be the consideration for surgical intervention if the patient is presenting with localized disease that is failing to maintain a good level of remission. Post-operative prophylaxis may be warranted in certain patients. That might get operated for Crohn's disease because around half of the patients may develop some endoscopic recurrence within 5 years. That being said, not everybody does develop clinical recurrence because that follows with about 25 to almost 50% with the recurrence within those 5 years. All agents are good in reducing the endoscopic and clinical recurrence except for anticord and mesalamine, and the biologics have been noted to be the best. Moving on to the perianal Crohn's disease. Now that's a huge other chapter, so I am not going to delve into the details of each point of these managements. However, discussing the principles of management in anorectal disease that present with Crohn's disease patients, it is important to understand and to always be vigilant of perianal disease that may present with those patients, because up to a third of Crohn's patients may have perianal disease. And it is also important to be able to differentiate Crohn's patients that present with simple perianal disease as a complication of what's going on during their bowel movements versus patients that actually do have Crohn's activity in their perianal region. They may present with anything from tags to fissures to ulcers to abscesses, fistulae, strictures, and the unfortunate complications of adenocarcinoma and squamous cell carcinoma. Overall, the presence of anorectal disease may suggest an overall more aggressive disease. For you guys as general surgeons, it is important to understand that controlling sepsis is the mainstay of your therapy, and when those patients present with acute anorectal disease. After the control of sepsis is when we may allow our colleagues to institute medical therapy. Steroids have not been shown to be very effective in managing perianal Crohn's disease results in the setting of fistulizing disease. It is important to note that controlling the GI activity, especially in the rectum, is very important in order to achieve some success or good success with the perianal disease. Because as long as the rectum is inflamed or is showing severe activity, then there will always be concern for healing, incontinence, and recurrence of that disease, and even concern for malignant degeneration should the problem persist and not show any response. Finally, diversion and or proctectomy, even though it says 10 or 20%, ladies and gentlemen, I have to say that it's present. I know it is a low number, but it is present, and you do see it every now and then. So educating your patients earlier on and trying to achieve good control of the perianal disease, I think, is paramount, because the majority of these patients tend to be of a younger age, and I think that it is quite unfortunate that some of these patients end up with proctectomy or sometimes even abdominal perineal resection at a very young age due to the severity of the disease. Anyway, moving on, skin tags, type 1 and type 2. Type 1 tends to be the edematous heart type that typically arises from fissures, ulcers, or hemorrhoids. They also tend to be known as the sentinel tags. The other type is the elephant ear. They are not common at all, and they really do look like elephant ear, and the biggest issue with them is hygiene and the itch or the anal pruritus. Again, you have to be very vigilant before you start going any of these skin tags, because healing might become an issue if there's an activity in the rectum. Hemorrhoids tend not to be, you might see it especially with patients that do not have any active perianal disease, but they have significant amount of diarrhea or alternating constipation and diarrhea. And again, you have to be very careful about any surgical intervention in these patients because healing is poor. Fissures and ulcers tend to be more present than hemorrhoids. They tend to be the atypical fissures. They tend to be the atypical ulcers. So they do not necessarily present in the classical posterior midline or the 6 o'clock position. They may be multiple when they are present. They tend to be, again, just like the regular patient, they are very painful. They may bleed. They may cause pruritus. They may cause discharge. They may cause a lot of discomfort. A lot of them show non-caseating granulomas when you take biopsy, and that in itself is indicative of severity because that shows that the perianal disease is in itself part of the Crohn's entity. It is the non-surgical management is as far as you want to take it with these patients because pouring will be very poor with these patients. Patients that present with ulcers must rule out other causes such as infection by syphilis, HIV, herpes, TB. Topical flagell or topical tacrolimus sometimes have been used with limited success. But I think that the most successful out of all these medications so far have been the biologics. Abscesses that present must be drained as an emergency, and these may present in up to 80% of Crohn's disease patients. There's no need to pack them. It's really, I mean, packing is something that should not be taught anymore. It is a torture. The only time I may consider packing is after making the decision, and it would be usually for the purpose of hemostasis more than anything else, and that would be removed promptly after a few hours or the following morning. The technique of incision, I think, is important, especially when you're dealing with a complex or a large incision, because a lot of these patients, namely more than 50% of these patients, will convert to a perianal fistula, and having a short course perianal fistula is easier to manage down the line than having a very long course of a perianal fistula tract. Moving on to the fistulas that I was just talking about, they may be simple, they may be complex. For you as surgeons, when you're managing these, the preservation of continence and the sphincters are important whenever you're considering your therapeutic options for your patient. Control of proctitis is paramount, because as long as there is rectal inflammation, in my opinion, then the fistula will never successfully heal. And if it does heal, then there's a high chance of recurrence. Diarrhea will always complicate your management, so that is also something that you need to control the symptoms of your patients. Salicylates, sulfasalazine, mesalamine, and steroids are not very effective in treating perianal disease, namely fistulae and the ulcers. Metronidazole have shown some success, but I think, like I was saying again, biologics have been shown to be I think they are becoming the gold standard now for treating those patients. Infliximab has been the one that was studied the most. It shows 50% success in the closure or the reduction of the number of fistulas, and it tends to show its effect and may indicate the removal of acetone after the second dose of infliximab. However, the median time of closure may take up to 3 months. These may be higher success if they're combined with surgery, and in terms of surgery, I do mean either placement of acetone in order to control the disease initially, or towards the end of the line of your medical treatment where the patient has shown significant response to your biologics, and you're dealing with a very complex fistula where you know it's not just simply closed by pulling the acetone out. Then you may schedule surgery towards the end of your treatment. There's a slight risk of relapse whenever it's discontinued. I don't think that it is well studied yet, and we are waiting for these numbers. Humira is slightly less successful, but it may be used again in non-responders with Remicade. Surgery, the primary treatment modality should be cetones. These tend to be temporary, especially if the patient shows good success or response to your therapy. Sometimes these cetones may end up being permanent, and I do not think that having permanent cetones in your patient is a wrong thing to do, nor does it represent failure of surgical therapy, because the alternative may be a lot worse. And fistulotomy, in my opinion, should be reserved for the very, very simple intersphincteric and transsphincteric low fistulas with very minimal rectal disease and GI disease and good continence. And as a matter of fact, this is such, you know what, actually, this is such a selective group of patients that I do not think, I think I'm going to pull an Ahmed and say, refer to a colorectal surgeon. It is composed of fibrin. It is not very successful, but it's not really harmful. Especially if your patient has undergone previous surgery or continence an issue, or your patient is selective in their method of management. Plugs have been used. They have a very wide range of success, less success with IBD than non-IBD patients. It works by allowing the deposition of collagen, producing fibroblasts. It's harmless Well, actually, I can't say it's harmless. It provides little harm because one of the complications may be an abscess. Lift is also known as ligation of interfistula tract. It has relatively good success, especially when it is used with a biological graft. But most of this data has been derived from non-Crohn's patients. And similarly, rectal advancement flap has been noted to be successful more in non-Crohn's patients than Crohn's disease patient, and that's why selection, I think, is paramount before you put your patients through extensive surgery like that. Moving on to the more drastic and unfortunate surgical interventions, diversion. It is actually very effective in resolving perianal disease in a significant number of patients, more than 3/4 of them. But then the issue arises when whenever you do have that success in the control of disease, what's going to happen when you restore the GI tract? The issues of recurrence with restoration is present and is not really known. Proctectomy might be the end unfortunate result of about 10 to 20% of severe perianal disease. And that might result from either severe anal strictures or severe active proctitis that is refractory to all intervention. Complicated fistula disease have been an indication, and dysplasia and malignancies have been noted and have been known to be the reason for proctectomies and even abdominal perineal resection. Rectal disease is very present. It's commonly in patients that have persistent proctitis or patients that persist with their diarrhea as a main symptom. Up to half of those patients tend to be a rectal stricture rather than an anorectal, and therefore differentiation is important in selecting your management or your surgical options. Anal cancer, it is not common now to say, but however, they are considered a higher risk population due to the persistent inflammation in the region. And even though the normal population tends to be a squamous cell carcinoma, with Crohn's disease, it is known to also have adenocarcinoma due to the fistulizing nature with some of these patients. The treatment is as per guideline of these malignancies. Moving on to surgical, and I'm sorry this is taking a little too long, but I'm going to try to hurry up. Indications of surgical interventions. Intractability, I think, is a very subtle but an important indication to operate. And intractability to maximum therapy basically is are patients who fail to achieve adequate disease control or develop complications from medical therapy or just simply not compliant to therapy. The decision to wait and operate should always be individualized, that the decision to diverting your patient should always be individualized, and therefore the discussion of these patients in multidisciplinary team meetings and including a colorectal surgeon in the decision making, I think is important. And patients that are receiving biologics or active immune suppression or steroids may warrant a stage procedure due to the nature of perioperative complications. Inflammation is another indication in Crohn's disease. The signs of impeding or actual perforation obviously need to be promptly operated on. Acute severe colitis in Crohn's disease is defined by more than 6 grossly bloody bowel movements with one sign of toxicity. When it becomes more than 10 bloody bowel movements, it turns into a fulminant colitis. Toxic megacolon is when there's a dilated segment or the entirety of the colon is dilated with signs of toxicity. Endoscopy may be used sometimes, and it may be important to help differentiate patients that may just arrive with severe colitis from the moment they walk in through the door, and they're just not responding to your treatment, and you want to differentiate whether this is infectious or non-infectious in order to direct your treatment between immune suppression or active antibiotics. Putting your patient in NPO, hydration, nasogastric decompression, and broad-spectrum antibiotics are important at that point. Management with IV hydrocortisone, which may take up to 3 days to show their effect, may be added with biologics, and they usually show within a week. Another indication for surgery in Crohn's disease is stricture. They may present usually as an obstruction. Endoscopic assessment of non-urgent strictures is important because it gives you the therapeutic option of dilating these strictures or anastomoses if they have a flare-up. If the stricture is inaccessible endoscopically, then it may be assessed radiologically. However, a stricture that may not be approached endoscopically is an indication for surgery. These strictures may be inflammatory or fibrous stricturing in nature, and an MRI may help differentiate that, or an endoscopic examination with some biopsy will help differentiate that. Short segment disease is more amenable to endoscopic dilatation. The endoscopic dilatation that you're trying to achieve is up to 2 centimeters in diameter, and usually 2 dilatations will achieve up to 5 years successful dilatation without any significant symptoms. However, it is important to note that due to the inflamed or the stenosed nature of these strictures, that they run a slightly higher risk with complications. If the stricture is not amenable to dilatation, then surgery is indicated, or if it is a long segment, then it should be operated. Or obviously, if it is obstructive, then it should be intervened surgically. Strictureplasty may be considered in a non-inflamed or non-phlegmonous stricture because these tend to be fibrous. That we will not get into. However, the most common 3 types of strictureplasties that I may utilize are the Henneke-Michelix or the Finet or the Jablé techniques. Overall, they may have 10% risk of complication of either flare-up or restenosis, or the most feared complication would be a leak from that strictureplasty. Colonic strictures are usually not amenable to dilatation, and colonic strictures that are non-traversable should be elected for surgery. Penetrating disease in Crohn's disease, obviously if it's a free perforation with peritonitis or systemic toxicity, it requires an emergency intervention. Small bowel usually is resected. You may consider diversion based on the clinical scenario. And if colonic perforation occurs, again, resection with diversion or an instillation. And these are all dependent on several different factors such as continence, proctitis, and the location of the anastomosis. With penetrating disease, you may, if it is not a free perforation, obviously that does not require an emergency surgery, the patient may present with either fistulas or abscesses. Abscesses may be treated with antibiotics, plus or minus drainage, depending on its location, accessibility, and size. The usual size for drainage is, depending where you're reading, it really says between 3 and 5 centimeters. So I'm just going to take the mathematical average of 4 centimeters and the experience of your local intervention radiologist. Obviously, the patients that fail percutaneous drainage will require surgical resection. But it is important to know that surgical drainage is successful in about 1/4 to 3/4 of those patients, and is successful in converting an emergency surgery into elective surgery with a reduction in overall complications with a similar rate of fistulas and anastomotic leaks. Sometimes, occasionally, with certain patients that have an excellent response to anti-TNFs, it might avoid surgery altogether if they show good response. Patients presenting with fistulized or localized systemic sepsis despite appropriate medical therapy should be considered for surgery. And that is because they are considered to be uncontrolled fistulas, and therefore these should be drained operatively with control of sepsis and surgical resection centers. Hemorrhage, another indication. It usually is controlled successfully immediately on biologics, may sometimes respond to non-operative management. However, as we all know, if these modalities, the patient will require surgical resection. And growth retardation is a very important but very frequently missed indication for operating on these patients, because it tends to present in about and up to 40% of pediatric population. And surgical intervention will eventually help the patient catch up to whatever they lost within 6 months. Neoplasia is, so with IBD, the classical neoplastic scenarios have always been associated with ulcerative colitis. However, we do know now that Crohn's disease does carry a higher risk than the general population. It might not be as frequent or as high as the ulcerative colitis. However, we do know that it is higher than the general risk of the general population. So endoscopic surveillance for long-standing ileocolic and colonic disease is important. It should not be delayed more than 8 years. And whenever you do screen these patients, it is a tedious process of taking random 4-quadrant biopsies every 10 centimeters in order to rule out anything such as dysplasias. What about other indications that are non-neoplastic necessarily, but may indicate high risk for cancer? So primary sclerosing cholangitis does confer a higher malignancy risk, and it is an indication for annual colonoscopies, screening colonoscopies at an earlier age. It is also an indication for prophylactic total proctocolectomy. Because about up to 40% of patients undergoing segmental resection for cancer will eventually develop intestinal cancer, and hence there is a strong reason to advocate for total proctocolectomy in those subset of patients. And also other indications, like I was mentioning, are high-grade dysplasias, multifocal low-grade dysplasias, and which is known as the dysplasia lesion of mass, which are usually non-adenomatous and may show on chromal endoscopy. Site-specific surgery. When it comes to the stomach or the duodenum, you should avoid resection whenever you can. Endoscopic dilatation and stricturoplasties have been the mainstay of therapy with usually good success. Whenever it comes to the jejunum, ileum, and the ileocolic disease, it's usually resected and anastomosed. However, when you're dealing with short gut syndrome or short bowel, then you may have to consider other surgical options. What about Crohn's colitis? Ideally, the optimal surgical therapy is total abdominal colectomy and ileostomy for patients that present with colitis and not pancolitis or proctocolitis. Patients with segmental disease and rectal sparing may be offered segmental colectomy. Now, I want to emphasize that this is the only situation where segmental colectomy should be allowed, where you are having disease, where you are having rectal sparing, and you don't show any evidence of dysplasia or malignancies. If you fall into any of the other categories, then what is recommended for you is to have a total proctocolectomy. If you have rectal involvement, or if you have rectal sparing, then it is a total abdominal colectomy because you are sparing having to operate on the patient's pelvis. J pouches or ileopouch anal anastomosis are ill recommended for IBD patients. Are ill recommended for Crohn's patients due to the risk of complications. Medications used in surgery for Crohn's disease patients. Steroids have been found to have the highest association with anastomotic leaks, up to 40%, as I mentioned earlier, and it is really therefore a strong indication to consider either diverting or weaning off the steroids before operating on your patients. Thiopurines and anti-TNFs appear to be safer when compared to steroids. Biologics have been even found to be safer than thiopurines and anti-TNFs. Unfortunately, anti-integrins such as Entyvio have been associated with a higher surgical complication rate when it is compared with anti-TNF. Now, this last fact is under constant review because it does seem that it is not as high of a complication rate as we initially feared, but it is present and it is known to be higher than the anti-TNFs such as Remicade and Humira. And generally speaking, in meta-analysis, the use of steroids and immunosuppression and anti-TNFs do appear to be associated with higher complications. So whether we're talking about safer profile or a higher risk profile, avoiding all these drugs in general, if we can, is always a better option. principles of surgery when you're dealing with a Crohn's patient is that you're constantly going to have a thicker mesentery, and this is something you're going to have to consider when you're taking down your mesentery after your bowel resection. You may have to use clamps, you may have to use energy devices. When you're resecting the disease, you do not chase microscopic disease because this is something that is not feasible intraoperatively, and therefore you limit your resection to macroscopic disease. The method of stapling, whether stapled or hand-sewn, this is a topic I think that is constantly going to be in evolution. I think when staples first came out, people were afraid that the foreign body inflammatory reaction that is caused by the staples might run a higher risk of relapse or local recurrence, and then there was a slight trend towards moving to hand-sewn. But with the advent of better technology, we realized that staple do not infer necessarily a higher rate of recurrence, so there was a slight shift towards staples. Again, this has been put back into question again because there has been a recent trial that compared the standard stapling to what is called a Kono-S side-to-side anastomosis. It is a Japanese technique. And in all honesty, I was very impressed by the fact that the rate of recurrence or failure of these two anastomoses have been shown to be equal, and none is inferior to the other. I think that a side-to-side anastomosis is always better than an end-to-end whenever it is feasible, because should the patient recur down the line at their anastomosis, then you want to have a wider loop from an end-to-end anastomosis. Diversion should be individualized, and I think most patients should get a laparoscopic approach opportunity whenever it is feasible and safe. Nutrition is always important, and immune suppression and biologics should be weaned down whenever possible. In ulcerative colitis, patients that present with acute colitis, they have a sign of impeding or actual perforation, as always, and as they should always be promptly operated on. Patients that have acute severe colitis, as we named earlier, presenting with more than 6 grossly bloody bowel movements with one sign of toxicity, or fulminant colitis with the presence of more than 10 bloody bowel movements with signs of toxicity, or toxic megacolon that is represented by the transverse colon diameter of more than 6 centimeters with signs of toxicity. About a quarter of these patients will eventually require emergency surgery. Whenever they perforate, they carry an associated risk of additional mortality, and that risk of mortality is proportional to the time of operation, and therefore delay is it's not something you want to do. The surgery type we will be discussing in a little while, and patients that fail medical therapy within the 4 days should strongly be considered for surgery. And therefore, that's why I always say that early involvement of surgical consultation is paramount with these patients, because it's not fair to leave the patient, to leave the surgeon having to make that decision with the first 5 minutes of interviewing the patient. There's a better patient relationship establishment when the surgeon can come earlier on and assess and discuss with the patient that there will be a definitive plan early on that we will institute either hydrocortisone and then escalate to infliximab breast infusion, and should that not show any signs of response, or should they worsen, then the next safe thing to do is operate before a perforation occurs because of X, Y, and Z. I've always found that puts you at a better relationship and trust. And you definitely don't want to leave your patient having to make that decision when they are in that extreme situation down the very end. Intractability of therapy to ulcerative colitis, just like Crohn's, is also an indication to operate. Again, this is when you do not achieve the desired effect, or you have to give too much of a dose in order to achieve it, or the loss of the social life or school progress or working hours are all indications to operate on a patient. Also, achieving the medical effect but having a significant side effects may also be something that is considered to be an indication to operate. A non-compliant patient obviously is one of those categories. Extraintestinal diseases may be considered, however, like I said before, erythema nodosum is the one that shows the most promising response to operation. Otherwise, the other ones do not show significant response to operating. However, the presence of extraintestinal diseases may be in itself an indication of intractability or an indication to operate, especially the primary sclerosing cholangitis, as we will talk later on about. Growth retardation is also considered a failure of medical intervention, and surgery should be discussed. Cancer risk in ulcerative colitis, it is known, especially in the presence of long-standing active disease, and therefore surveillance is paramount, especially after 8 years from the onset of diagnosis for pancolitis. When you're presenting with distal colitis, that category of 8 years may be relaxed to 10 to 12 years. And like I said, primary sclerosing cholangitis is an indication of 50% risk of cancer or dysplasia at a 25 years point of from the day of diagnosis. Screening colonoscopies have to be done at a 1 to 2 year interval, and the surveillance has to be done with 2 sets of 4 quadrant biopsies every 10 centimeters of the colon and the rectum. Surgery is indicated for any patient that shows high-grade dysplasia or non-adenoma Bowel or does show carcinoma, because there is evidence behind the dysplasia carcinoma progression. And also to point once you get into high-grade dysplasia or non-adenoma, then there's up to 50% chances of having a concomitant malignancy at the specimen after resection. Total proctocolectomy is recommended in addition to surveillance for any patient that show low-grade dysplasia, although in all honesty, I do mention to the patient that whenever they do develop low-grade dysplasia, even though surveillance might be an option, eventual stories that low-grade dysplasia will turn into high-grade dysplasia and be indicated for operation. Strictures are a strong reason to operate in ulcerative colitis patients, because 25% of ulcerative colitis patients' strictures are malignant, and up to 30% of malignancies in UC patients are usually malignant strictures. When it comes to an emergency surgery with UC patients, then the ideal operation is total abdominal colectomy and ileostomy, because it removes the bulk of the disease without having to negotiate with the pelvis on an emergency setting. And it also it is shown to restore the health of the patient with the greatest reliability and the least amount of risk when compared to a total proctocolectomy. However, when it comes to elective surgery, then a total proctocolectomy and an ileostomy is an acceptable solution, and it is considered to be the safest solution, and it is the benchmark out of which everything else gets compared to. A total proctocolectomy and a J pouch or an ileal pouch anal anastomosis is also appropriate for selected patients, and let me re-emphasize that it is appropriate for selected patients. And just because you do not have cancer does not mean that you should be or that you are a UC patient, that you should be a candidate for a J pouch just because that you're not Crohn's you're using. Because there's a lot of things that do play in the success of fashioning a J pouch for your patient. And things that do go into play whenever you're considering the proctectomy and the J pouch formation are things such as sexual function and fertility, which or infertility rather, which may be present in up to 60% of females. And again, when the patient, especially the female patients, or obviously the female patients do get pregnant, then there is a risk between pregnancy and pouch in terms of outlet obstruction or a common cause for volvulus of pouches. Other things to consider when you're taking your decision to whether to give the patient a pouch or not are things such as cancer in the rectum and whether your patient's age. Things of consideration whenever you're performing the J pouch is whether to perform a double staple technique or a mucosectomy. Even though down the line it has not, neither technique has been shown to be superior in the absolute reduction of your colorectal malignancy. The pouch configuration may be in a J pouch configuration or an S configuration or a W configuration. However, in all honesty, all I've been seeing and dealing with are the J pouch configurations. Performing one versus multiple stages for the surgery should be individualized. Based either on the patient's situation and the experience. And finally, there's the issue of the continent ileostomy, which is, I think, is slowly disappearing part. You still have to follow up on the small risk of malignancy even after the total proctocolectomy and the J pouch formation of the patient, because you do leave a cuff of 1 to 2 centimeters between the dentate line and the pouch which you give your patient. You have to watch out for symptoms and signs of pouchitis, and sometimes you might have to perform a pouchoscopy. And you also have to keep an open mind for any pouch fistulizing disease which your patient might present with, because that is still a possibility. And if it does happen, then you have to revise your head and to consider whether the initial diagnosis was in fact not ulcerative colitis, but in fact now is Crohn's. Thank you. Does anybody have any questions before we move back to our 5 questions? And then I have the last question. I have an additional bonus question, which I'm going to be keeping as a semi-discussion point with either, with preferably a senior level resident.
Doctor, do you want us to start the poll?
Sorry, but the screen, I'm getting a lot of lag. Do you mind repeating?
Do you hear me now? Yes. Do you want us to start the poll questions? Yes. All right. So, would you mind reading the questions, Doctor?
Yeah. So the first question: which of the following extraintestinal manifestations of ulcerative colitis improves with colectomy? And it seems that the answer has changed from the beginning of the lecture. Most of these extra manifestations do not really improve, with the exception of erythema nodosum. Some of them might start progressing, but really the only one that improves, have been noted, is the erythema nodosum. The second question is: a 22-year-old female complains of daily sharp abdominal pain, weight loss in the past 6 weeks, 4 to 6 bowel movements per day for the past several weeks. Upper GI endoscopy is negative for disease. Which finding in colonoscopy would differentiate Crohn's disease from ulcerative colitis? Whether there might be some skip lesions in the colon, basically, which would be the answer for A, or whether the patient might have 2 perianal fistulas, as the answer for B. C would be a transmural biopsy in the distal lesion, or I beg your pardon, D would be her lesions have improved since starting prednisone.
We'll give them a few seconds to
Yes.
answer, and we'll share the poll so you can comment on it.
Yeah, so I think at the beginning of the lecture, the majority of the participants were answering A. Now I've made a couple of emphases during my lectures that even though the nature of ulcerative colitis tends to present in continuity, however, on a macroscopic scale, it may represent with some skip features. And that's why doing some random biopsies when your patient shows excellent response to rule out any microscopic disease that might be present between the skip lesions might show the fact that this is continuous ulcerative colitis rather than Crohn's with skip lesions. However, even when discussing that point, I think out of the 4 answers, the most definitive one is the one that relies on the histopathological analysis, which shows that the ulcer is transmural, and that's why answer C is the more appropriate answer.
All right, we can go to the third questions now. Yes. There you go.
Proctocolectomy in ulcerative colitis modifies the following risks: relative reduction in colorectal malignancy, total reduction in colorectal malignancies, total reduction in risk of colorectal malignancy and cholangiocarcinoma, or relative reduction in the risk of colorectal malignancies and cholangiocarcinoma.
All right, we'll give them a few seconds again to answer,
Yeah.
and then we'll share the results.
So somebody asked the question whether Crohn's disease is seen in people of particular ethnicity, region, or food habits, or is it hereditary? Yes, it is seen within certain geographical regions, countries, let me repeat that. It's seen more commonly in more industrial countries. It is more present in clusters, in familial clusters, so there is a genetic component. There's more than 30 genes that have been identified. The node 2 card 15 genes have been strongly associated with Crohn's, but all of these have been, I think, to put it in simple terms, have been more like triggers rather than a definitive causation. So if you're having these genes, it doesn't mean that you're always going to get those diseases, but you might have a higher likelihood of getting one of those diseases depending on your environmental factors.
Right.
Answering the question 3, unfortunately, no. It does not. So the presence of primary sclerosing cholangitis infers a higher risk of colorectal malignancy, but operating on the colon and doing a proctocolectomy will not reduce your risk of cholangiocarcinoma, unfortunately. However, because you are removing a source of chronic inflammation, such as the colon, you do significantly reduce the risk of colorectal malignancy. So, answer C and D are incorrect. They do not have any reduction in cholangiocarcinoma risk. When it comes to the reduction of colorectal malignancy, it is not absolute or total, unfortunately, because although you remove the entire colon and the rectum, however, still from a surgical perspective, we do leave a cuff of 1 to 2 centimeters at the very end well, not at the very end. We do leave 1 to 2 centimeters cuff ring, which will exhibit the columnar mucosal histology of the rectal mucosa, and therefore that 1 to 2 centimeter will still have that potential of turning into cancer. And that's why I said that it is important to follow up with your pouch patients. And it is also important to educate your patient that the risk is not absolutely, it hasn't gone all the way. We just reduced it down to 1 to 2% because of the presence of that cuff of mucosa.
All right. We can go for the 4th questions now. Yeah, there you go.
Somebody asked an interesting question, whether Crohn's can cause dental problems. It is something that I would definitely have to look at. I have not come across or heard of reports of Crohn's disease causing any dental issues. However, I would love to be corrected if there is any evidence, and maybe I should talk to my dental colleagues and dentist friends, and I'll add on to that slide for the next time. Question number 4. The most optimal choice for surgery in a patient presenting with severe IBD, panproctocolitis, who's not toxic and who's not a responder to steroids and biologics and biological induction is A, total colectomy and ileostomy, B, total colectomy and anastomosis, C, proctocolectomy and ileostomy, D, proctocolectomy and pouch anastomosis. The minute is up.
Yes.
So this was a trick question, and I'm hoping that the majority of the surgical residents are the ones that answered A, because I believe that A should be the answer given the wording of this question. So 1, I did not state whether this is a Crohn's or an UC patient. So having to embark doing a pouch on a patient that is not, who might be Crohn's, is not a good advice. So that's why I said it is a severe IBD panproctocolitis, because if both because a Crohn's or a UC patient may present in the similar picture, and even a biopsy may not be able to differentiate it, and therefore making that surgical decision will have to include the fact that there might be 10 to 15% chance of Crohn's. Number one. Number two, non-toxic. And then number three is a non-responder to steroids and biological induction. So non-responder to steroids and biological induction means that the patient has been tried on steroids and biologics, and therefore you do not want to do a pouch, and you do not want to embark on an ileorectal anastomosis on somebody who has just been before you take it to surgery. So option B would be ill-advised. And that leaves me with either option A or option C. And considering that the patient is presenting with severe IBD panproctocolitis, I do not advise that a proctectomy should be involved in the procedure on the urgent basis, and that the rectum should be left to deal with either on a second stage if the final pathology comes back as ulcerative colitis, or it may be left in place if the final pathology does come back as Crohn's disease and the patient responds to therapy. If the patient does not respond to therapy for that remaining rectal disease, then you may always go back and fight the rectum on a later date. So in essence, or in conclusion, a total colectomy and an endoleostomy would be the safest or the most optimal choice for a patient that is presenting with this IBD.
All right, I think we can go to the final question, question 5.
Question 5, the young male patient with Crohn's disease presents to your service with right iliac fossa pain. The workup shows leukocytosis and tachycardia. The examination shows a tender right iliac fossa. The CT shows a 5 centimeter loculation adjacent to an inflamed and a partially obstructing terminal ileum. The best route of management would be A, IV antibiotics, MPO or bowel rest and IV hydrocortisone. B, IV antibiotics, bowel rest and percutaneous drainage. C, IV antibiotics, bowel rest and surgical drainage. D, IV antibiotics, surgical resection, and IV hydrocortisone.
Right.
This is a similar answer to the pre-lecture. Maybe there is some I feel like there might be some confusion to differentiate percutaneous drainage from surgical drainage. When you're doing surgical drainage without the mention of surgical resection, I think that means going in, for example, with a laparoscopy, you suction out whatever dirt material or purulence in the abdomen and you place a drain. Surgical drainage, I suppose, is always an option that lays on the table, but with the presence of percutaneous drainage, I don't think that any patient should go under general surgery. I'm sorry?
Okay, yeah.
I'm hearing echo.
Okay, sorry.
So as I was saying, I don't think that surgical drainage should be an initial option when there's percutaneous drainage. Resecting the bowel, I mean, I did mention that the patient has a tender right iliac fossa without any generalized abdominal tenderness or peritonitis. I did not mention that it is a totally obstructing terminal ileum, and therefore the presence of the abscess with the inflammation may warrant a drainage first, and that may relieve the pressure of the terminal ileum and avoid having to operate for the obstruction if that was the indication for surgery. But I think the distractor and the answer D is placing the patient on IV hydrocortisone. That should only be as a perioperative measurement and not as a therapeutic measurement, because it might just increase the rate of complications for your patient. IV hydrocortisone is generally, or any immunosuppression is contraindicated whenever the patient has a loculation because it indicates an active ongoing infection. So A and D would be thrown out due to the presence of the hydrocortisone, and between B and C, B should be the safest option for the patient because it avoids having to operate on them. Now, should we go over the last case scenario, or should we answer some questions?
Now, while we upload the last case scenario, you can, if you can look at some of the questions, Doctor, and if you want to choose one of them to answer them, few of them.
Well, there's a gazillion questions. I'm going to focus on the Q&A panel first. When is surgical intervention needed in UC? We've discussed that in the lecture. Severe ulcerative colitis, which can be best steroids, infliximab, cyclophosphamide, which would you recommend? So, as I mentioned before, with severe ulcerative them with IV hydrocortisone is usually the standard thing that you would do before you start them on infliximab, because you do have to rule out other latent infections when you're starting biologics. Cyclosporin has fallen out of favor because of the safety profile that's associated with infliximab, and in all situations you have to rule out infectious causes before you start any of these immunosuppressants. What is your preferred surgical option for Crohn's disease? It really depends on the Crohn's disease and the patient. The use of antibiotics is continuous or in active relapsing disease only, or for complications. I tend to limit the use of antibiotics such as Flagyl for perianal disease. Sometimes I use it post-operatively when the patient might have stopped their biologics and have come to me for the definitive surgery. So I put them usually on their Flagyl as a slow dose prophylaxis until they're healing before they get back to their gastroenterologist. According to research, how is smoking protective for ulcerative colitis? I don't know. If you know, then you're going to be the next Philip Morris billionaire. It is just observational that smoking, or that people who are smokers tend to have less ulcerative colitis, or vice versa. However, it is more evidence-based to say that smoking is associated with a strong risk of relapse after operating on Crohn's patients. In the chat section,
we can take one more question and then we can go on the bonus question. Okay. Okay.
I think we can move on to the final discussion case.
So that's the bonus question.
Actually, let me share it from my screen.
All right. All right.
Unless it becomes a problem, then I don't mind.
No. Good.
Does it show?
1 second. Yeah, you can share it now, doctor. Try to share it.
Is it sharing?
Still not. 1 second.
Well, if there's any problems, okay, we can look at it through your screen.
All right. So, would you mind reading the questions, doctor, please?
Do we have a?
Yeah, I think that we have a R5 resident who's willing to take the question, the question. It's Dr. Mufarraj Al-Hajri.
Dr. Mufarraj, how are you?
We're just gonna we're gonna start first by letting everyone answer in the poll, and
sure.
Then so we're gonna share the poll now.
And if I would kindly ask that the senior level residents and above would answer this question, because I want to have a fair idea about their decision management.
Right. So, would you mind reading the questions for the audience, doctor?
So, it's a 25-year-old Crohn's female patient who's had Crohn's for about 5 years. She's on Humira and Imuran. She perforates her terminal ileum during a colonoscopy that was being done for a suspected rectovaginal fistula, and the colonoscopy was 12 hours ago. The colonoscopy showed sigmoidal proctitis, sorry. So that's why I wanted to read it from my question. I'm just going to read it from my screen. The colonoscopy shows improved proctitis and a terminal ileal pale deep ulcer with stenosis. On examination, she's 45 kilos. She's tender diffusely. She's tachycardic and she's febrile. During surgery, a previously noted contained perforation was noted at the terminal ileum. Disrupted, and there is a mild purulent fluid in the test. And I'm giving you 5 different surgical options on how you would want to manage this patient, and you may ask me or the patient, who's obviously not here, and I'll answer on her behalf any questions before you may take a decision, Dr. Faisal. The options are an omental patch for the perforation with a proximal loop ileostomy, or B would be an ileocolic resection of the perforation with anastomosis and then placement ceton of a rectovaginal fistula. C would be an ileocolic resection and an anastomosis and a proximal loop ileostomy. D would be an ileosection resection and a double barrel ileostomy colostomy. Or E would be an ileocolic resection with anastomosis. I forgot to write an anastomosis there. So it would be E would be an ileocolic resection and anastomosis and ileostomy proximally and the ceton placement of the rectovaginal fistula.
Right. We'll give them a few seconds to answer, and then we'll open the mic for to Dr. Mfaraj so he can share his answer. And
just give them like another 10 to 15 seconds, because question E is an ileocolic resection and anastomosis with loop ileostomy and ceton placement of the rectovaginal fistula. The anastomosis was not mentioned in E.
All right, we'll give them a few more seconds. Okay, I think Dr. Mfaraj Al-Hajri is with us now. And,
hi, Dr. Badr, how are you?
Hello, Dr. Mfaraj, how are you? I'm very well, thank you very much. Good to hear you.
You too, thank you. So for this lady, there is a few things that I should know before I decide my management for this patient. Most importantly, that how long she's been diagnosed with Crohn's disease and her bowel movement symptoms. How often she's having any diarrhea or bleeding, and is there any vaginal discharge that she noticed before the colonoscopy? And was there any feces coming from the vagina?
So just not to add up all the questions together, I will tell you that she's had, I didn't hear the first part of your question, but she's had about 5 to 7 years, sorry, let's say 5 years of Crohn's. She has gone through all her medications, and she's escalated all the way now to Humira and Imuran with the hope of some response. Her rectovaginal, she is in constant abdominal pain. This is her baseline. She does take some tramadol on a constant basis. She is complaining of chronic diarrhea, between 5 and 10 loose bowel movements that are painful per day. She does report some pain from her rectovaginal fistula, and she does report the excretion of I suppose some feces and some flatus per her vagina.
All right. So from the colonoscopy and operative finding that she has ileocolic disease and was complicated with perforation, although she had contained perforation. So in this case, she is tachycardic and febrile, and she has peritonitis and examination. I will go for ileocholic resection, and I'll do primary anastomosis. My thing is to do diverting loop ileostomy because the patient is she has low weight and BMI. She's tachycardic febrile, she's toxic, and she's sepsis, and she also appears to have bronchitis. And loop ileostomy will be a benefit for her that post-op that she can continue her medical management and hopefully resolution of the bronchitis. And regarding the RV fistula in patient with IBD, treatment will be only if there is associated abscess to be drained, and only to apply cetone to control the fistula, and to address this problem later on when she get treatment for the bronchitis, or definitive treatment of the fistula. And I guess that's my reason that I want to divert her, that she's sick, she has bronchitis, she has RV fistula. Fecal diversion, I think, will benefit hugely for her.
Okay. Now, will the fact that there was improvement of her bronchitis on the colonoscopy change your management?
Not really, no.
Okay. Would the fact, if I tell you that she is 150 centimeters tall and she's 45 kilograms, but all her family is just as the same physique? In other words, like this is not she doesn't have low weight. According to her and to her family, then this is within her norm.
Yeah.
Her norm, which has been present with her for almost 5 years, with the diagnosis of Crohn's, basically. But the rest of her family is just as skinny, skinny.
All right, so we'll get the BMI out of the equation. She has contained perforations, not clean surgery, and she has pus in the abdomen. I will not trust the primary anastomosis. I want to protect it. I want to treat the patient and get the benefit from the surgery with minimal complication. And as she has also the bronchitis, this hugely affects the diversion.
Okay. So my initial, just to go over the answers, before I discuss with you what I would choose or have chosen for that patient, just to go over the other answers, because per se, I think the majority of these answers, none of them would be wrong. The question is, what would be the most optimal thing that you choose for your patient? And first thing I would say, the confederate, well done. You have covered the majority of what I was thinking about when I was managing this patient, and your answer was not wrong. Doing an ileocholic resection with anastomosis and protecting with the loop ileostomy is a very safe and a definitive answer that nobody can find you wrong at, and I think that it is the second option that I would have taken, other than the fact that I've done something different. Going over the fact that doing an omental patch for the perforation with a proximal loop ileostomy diversion, it's not a wrong answer, but I think that it is unfair if you go in, if you're the person who's going to be in charge of going in and dealing with an acute Crohn's patient that has perforated, you need to be able to deal with Crohn's patients. Otherwise, you should be referring them to somebody who is a specialist, because doing a definitive surgery would be better than having to deal with an omental patch of perforation. That's number one. Number two, you must pay attention to the fact that during surgery, it was noted to be a contained perforation that was recently disrupted. And when I talked with her GI doctor, he said it was very weird. He went in, the rectum has improved, there was no evidence of proctosigmoiditis, and he went all the way to the terminal ileum. There was this pale-looking deep ulcer, and there was some associated stenosis around it. He took some very mild biopsies from around that ulcer, and after the colonoscopy, she immediately got sick, and she started showing signs of systemic inflammatory response. So putting this finding endoscopically and putting what I saw during surgery, it made sense to me that what the endoscopist saw was an actually old perforation that has sealed itself, or maybe a perforation on the mesenteric side that has dealt with itself. And all this patient was really complaining of from a GI point of view and a Crohn's point of view was her terminal ileal disease and no longer the additional proctitis. I and then I try to attempt to put a acetone for her rectovaginal fistula if her surgery was not cumbersome or extensive, or the surgery was very straightforward and she was doing very well. Then I'm just going to go ahead and try to do a quick EUA and put an acetone for her. And luckily enough, she entrusted me and she consented me to do all of that. And as I went through surgery and I started evaluating the bowel, the entire peritoneal cavity did not reflect her tachycardia and her tenderness on examination. Her abdomen was quite clean, and like I mentioned, there was just a small rim of pus in her pelvis. So I think that the majority of her SIRS response was due to her dependence on tramadol and her constant nature of abdominal pain. But that being said, what you said was also a valid reason for your surgical management. And in addition to her 45 kilogram weight, I asked for an albumin level, which was also handy and was provided to me without me asking for it or ordering it. And her albumin level was normal. So it indicated further to me that her 45 kilogram was within her normal weight. So I went in, I started with laparoscopy, which I always advocate. The abdomen looked very well. I ran her small bowel from the terminal ileum all the way to the DJ junction. There was no other evidence of active disease. She had no short gut. I ran her colon intraoperatively, and there was no external evidence of disease. So she did not have any other disease that was present at that point, except the part that was perforated, and the endoscopic proctitis which showed resolution. And the fact that she was not hypotensive, did not require blood transfusion, her albumin was okay, her level of hemoglobin was okay, and I was only having tachycardia and tenderness, I decided to resect and anastomose without diversion for the sake of her anastomosis. And then the next question that popped into my head is, do I still need to divert her for the sake of the proctitis or her fistula? And then I decided is that having to do a diversion for a rectovaginal fistula would be considered one of the most extreme solutions to a fistula that has failed all other forms of intervention. And it would be somewhat unjustifiable to give an ileostomy for a patient that has shown resolution of her proctitis and has never had any attempt of treatment of her rectovaginal fistula, such as draining any present abscesses or draining her or placement of any cetones. And therefore, I elected to do a resection anastomosis and no loop ileostomy. And after I concluded the procedure, I completed an EUA because the procedure went relatively well. I did an EUA for her with an attempted placement of a rectovaginal fistula. So I did answer B. And thankfully enough, the patient did relatively well without any complications and went home post-op day 6 or 7.
Right. Thank you a lot, Doctor, for the bonus question, and thank you, Dr. Mufadaj Al-Hadri, for joining us today. And I would
You're
like
more
to...
than welcome. If I may just say, the reason why I wanted to put this as a discussion question is that the easy answer is always provided. You know, we all know the easy answers that are always provided in the textbook. Resect, anastomose, divert, or resect and divert, and get out of there. And sometimes having to take the more difficult decision is why we tailor our treatment towards our patients. And that's why I always think in this day and age, having to give the subspecialty its right in decision, in the making of the decision, will always incur benefit towards the outcome of the patient. rather than anything else. And thank you for the talk, for giving me the opportunity to talk.
Thank you so much, Dr. Badr Shaban, for this informative session. And we kind of passed our time, so we cannot answer any other questions.
I'm sorry.
Yeah, but thank you so much, Doctor. And it was a pleasure to have you on our platform.
The pleasure was all mine. Thank you very much.
Thank you. If you all of our participants can stay for 10 more seconds, we're going to share a list of QR codes for our next session, which is going to be about anorectal disease with Dr. Jassim Al-Abbad. You can take out your phone and scan the QR code in the middle. You can also access our website for all the previous session, and you can listen to our podcast through Spotify and Apple Podcasts. And don't forget to check our Twitter and Instagram account. Thank you all for attending today. And thank you again, Dr. Badr Shaban, for this wonderful lecture. And we'll see you next week. Thank you.
Inshallah.
We're going to leave the PowerPoint few minutes so you can take your time to check everything. Thank you, everyone.